Hi, everybody. Good morning. Welcome to CVI. I hope you had a great evening last evening. And I'm David Kandzari from Atlanta, Georgia, along with my co-moderator, Tim Henry from Cincinnati. And this is a welcomed opportunity to be part of a program to expand our knowledge about lipid management and its relationship to coronary revascularization and disease. We're going to start off just keeping things on track and with discussion after each presentation. Our first speaker we invite is John Lopez, who will address the 5 most important PCI trials of this past year. Welcome, John. Thank you.
Thank you, David. I guess I'll use this mic. I think this is my 3rd time at this meeting. I love this meeting, and I'm honored to be here. This is a fun talk, the 5 most important PCI trials of the year.
John, here's a clicker.
That's what I'm looking for. Look at you holding out on me.
Yeah, we're trying to.
We can go to that CVI circle.
That's the spot?
That's the runway.
All right.
Yeah.
Those are my disclosures. So the 5 most important PCI trials of the year, I tried to do this talk by looking at the major categories, right? Imaging, procedural approaches, physiology, drug-coated balloons, and newer paradigms. And if we start with the imaging or intravascular imaging, it's really been a banner year, right? In the last year and a half, we have a number of really important trials in this space: the Illumient trials, the October trials, Renovate PCI, Occupy, IVUS ACS, and a really important Illumient 4 sub-studies as well. So I chose to talk about the Occupy trial. Why? Because this is really an important randomized trial. It's not a sub-study. And it confirms the findings of several other trials in this space over the last year: Illumient 4 and the sub-studies, the Renovate PCI trial, which was an OCT and IVUS trial, and the October trial of OCT and bifurcation lesions. So this particular trial is a really interesting trial. It came out of Korea, 1,600 patients comparing angiographically guided PCI to OCT-guided PCI, where at 1 year, similar to many of these other trials, in complex lesions, and complex was defined fairly broadly: long lesions, bifurcation lesions, calcified lesions, small vessels. The use of OCT guidance really improved outcomes, which a much lower MACE rate, a hazard ratio of 0.62, suggesting, again, like many of these other trials, that the more complex the lesion, the more there is a value in intravascular imaging, in this case OCT. But what I found really important about this trial is that not just that endpoint, but that the operators really defined what is a successful or optimal PCI based on OCT imaging. And they really set criteria. If you look here at the top, they set criteria based on edge dissections. Let me go back here for a second. How the stent was expanded and whether the stents were fully optimized. And if you look at the right graph here, that if you had an optimal stent placement with OCT guidance versus suboptimal stent placement, the hazard ratio was 0.33. You had 1/3 fewer as number of events with optimal versus suboptimal PCI with that type of OCT guidance. So this study really suggests that it doesn't matter just to do imaging. It matters that you interpret it and you use that data correctly to guide your procedures. So when we talk about procedural approaches, this is really the year of the Eclipse trial, right? Why is that? Well, because it really affects practice patterns immediately. It adds to our understanding of complex calcified lesions. But it doesn't really mean the end of calcium modification or procedure modification, as the headlines might suggest, right? So this is a trial of 2,000 patients, randomized to orbital atherectomy versus balloon angioplasty preparation before drug-eluting stent placement. And what is notable about this trial is where these arrows are here, that intravascular imaging guidance was incredibly high in this randomized trial, over 60%, right? Far exceeds anything we see in routine practice. The use of orbital atherectomy really carried with it a higher contrast volume, higher procedural time. But much to the surprise of many, this trial showed, in fact, that although orbital atherectomy preparation trended towards a higher minimal stent area at the end of the procedure, it didn't meet statistical significance. And with this high level of imaging guidance, they saw really no significant difference in the primary endpoint at 1 year, or in any individual component of this primary endpoint. Now, one of the take-home messages here is that the procedural success of either approach in this study were identical. And that's very different than the rotational atherectomy trials of a few years back. And it suggests some improvement in our ability to use the tools we have outside of ablation to prep these lesions, and that perhaps with imaging guidance, the routine use of orbital atherectomy doesn't really have a benefit. So it certainly doesn't eliminate the need for this approach, because there had to be equipoise to get into this trial, meaning operators who thought that orbital atherectomy was absolutely necessary were excluded from this trial, but it does sort of give us a little bit of pause. So what about physiologic evaluation? Well, a number of trials this year. The one I'm going to focus on is the FAVOR 3 Europe trial. Why is that? Well, there really is a growing interest in non-wire-based assessment of coronary physiology, and yet there are very few randomized trials in this space. And really the question here is, are these approaches as good as quality randomized trials, and is it really cost-effective? So if you look at this trial, which used this quantitative flow ratio versus fractional flow reserve to guide coronary revascularization, a 2,000-patient trial in Europe, where quantitative flow ratio is really a computational model based on angiography. And with that approach, you'll see here in red that the number of lesions identified as functionally significant, the number of vascularizations, and the number of stents were significantly higher in the QFR group. And across the board, it's about a 20% increase. And with that 20% increase, we see that translated in a MACE rate at 1 year that's about 20+% higher. So an absolute difference of 6.7% MACE rate versus 4.2%, suggesting that this QFR approach really only has about an 80% concordance with FFR, leads to higher revascularization and higher number of repeat procedures. This ultimately is not a non-inferior trial, meaning this 2.5% absolute difference between groups. If you take this on the bottom here, this 90% confidence, upper limit confidence interval of that 2.5%, it exceeds the preset non-inferiority margin, making this a negative trial. At the end, then, this QFR approach is not as good as an FFR approach and raises a couple of questions, not just about whether we should be using this routinely, but whether one of the touted benefits here, that this is cost-effective, really is true or not. So drug-eluting balloons in the last year, we know about the AGENT trial. I want to focus for a minute on some of the other questions about drug-coated balloons, and there are many of them that have yet to be answered. This trial, the ultimate trial, is a smaller trial that's looking at whether we should routinely be using imaging to guide this approach. 260 patients, a trial out of China, showing that using IVUS guidance with drug-coated balloons leads to an increase in drug-coated balloon size with imaging, a higher degree of bailout stenting in this population where they tried to limit the number of stents, but a lower late lumen loss, and fewer clinical events, although this didn't meet statistical significance, suggesting that this, in fact, is probably a pretty good approach, right? And then finally, when we think about newer approaches to things, I want to focus for a minute on the PREVENT trial most of you are aware of. This is a trial of preventive PCI versus optimal medical therapy for non-flow limiting FFR negative lesions defined as having vulnerable features. Now, is it truly vulnerable plaques? Maybe not. Many of the patients who got in this trial you'll see here are in this trial related to a small lumen area, a high plaque burden, but there are also NIRS and OCT criteria for vulnerable plaques that were included. The use of stenting or treating these preventive lesions resulted, as you'll see here, in a lower event rate at 2 years with very small price to pay for this preventive approach, but that these differences continued for up to 7 years follow-up, suggesting perhaps we should be thinking about who we're treating, not just the functional significance of these lesions. So I'm going to conclude here for a minute, and these are the conclusions. Intravascular imaging is king. There's now overwhelming evidence that this should be a routine part of our approach. The more complex the lesion, the more we should be doing it. Non-wire-based physiologic measurements may not be as good as you want them to be. And we should really consider whether one of the touted benefits of this, that it's going to save your lab money, is really true if there are more procedures and more follow-up procedures with this approach. Calcium modification strategies remain important, but are an evolution and patient selection matters. And the DCB era is really off to a slow start. There's an incredible number of questions left in this space that have to be answered. And lesion phenotypes probably matter. Not all non-significant lesions carry the same risk. And it may be time to start reconsidering who we're treating and how we're going to treat them moving forward. So I'll stop here.
Thanks, John. I want to take 3 to 5 minutes just for some discussion here and open it up to comments from our audience and our panel too. But just to key things off, John, you so well addressed hemodynamic assessment, intravascular imaging, drug-coated balloons, orbital atherectomy versus other methods, and plaque sealing. But if you're going to pick one trial that's most influential over the next year to influence clinical practice, which one would it be?
Wow. That's tough, Dave. I would say that probably the ECLIPSE trial, I think, had the most immediate effect in sort of not expanding what we do and really rethinking where we're at. I think it was really eye-opening to see what's changed since a similar type trial was done in the rotational atherectomy space 10 years ago. And I think it doesn't eliminate the need for this approach, but it really makes us rethink with the new tools and approaches we have today, whether we really need to use that tool as often as we do.
Let me also just, you got a comment?
Go ahead.
Yeah. Well, one other corollary to this is talking about imaging. So you're absolutely right. The evidence is overwhelming for imaging and improving outcomes. And I can share as Kath of the PCI registry that still in the United States we're about 25% application of intravascular imaging,
Right.
and OCT in particular is in the low single digits. And what do we need to move the needle in this space as well? I know Mauricio's going to have a comment here. There's a microphone there, but John, you go first.
Yeah, well, I think there's a lot of reasons that the needle isn't as high as we'd like. And I think it's happening. I think it's happening with the generation that's younger than ours, right? And that's where it's going to happen, right? But I think there's cost issues, there's reimbursement issues, there's sort of capital equipment issues. All those things limit the adoption of this. But I think at the end of the day, it's going to be a slow ramp up in how this happens. I think there's enough evidence out there that if it hasn't happened overwhelmingly at this point, we can't put more data out there to make it happen. I think it has to sort of slowly churn the wheels of the administrative bureaucracy we all deal with, really.
So, John, I want to follow. I brought this up yesterday, and it kind of dropped, but I want to push it a little bit. ECLIPSE was fascinating for a number of reasons. First of all, no overall difference, but only 60% imaging. And when you looked at the imaging, the patients who did imaging did better, okay? But both with balloon and with the orbital atherectomy. But then there was, at ACC, Greg Stone did a look at OCT versus IVUS in calcified lesions. And clearly, OCT looked much, much better. And from my perspective, the new OCT, all of the new things, including the AI and the automation, it seems to me for calcified lesions in particular, OCT has huge advantages.
I agree with you, Tim. I'm a big OCT operator, as you know. We're about to publish a sub-study from the Illumian trial that looks at pre-procedure OCT imaging and stratifies patients into the plaque type pre-procedure. And for the first time, we'll see that OCT can differentiate 3 different phenotypes, and that the outcomes are very different based on the phenotype that you determined before you stent. So I think there's a whole world of this pre-procedure imaging that we can get from OCT that we can't really get from IVUS and other features that's really going to impact on how patients do and how we predict. So I think there's a whole world that we haven't explored that's not just what the imaging shows at the end of the procedure, but what happens at the beginning that's sort of really going to change things a little bit even further.
I'd like to highlight actually what John just mentioned, that if you were about to do one run of actually imaging, I think that should be the because that will give you a lot of information. And being honest with us, I remember we had the experience multiple times that it de-escalated our plan. So there was a lady with ACS lesion that I thought initially is going to be a calcified lesion. I have to make myself ready for some sort of atherectomy, and then we do OCT, and it is actually a thrombus. So we go in and direct stent the lesion and be done. So it's not always that you do imaging, you have to do more. Sometimes you do imaging, you understand the lesion better, you do less. And to my eyes, it's something I always tell fellows, if you see a vessel, it's 3.5, you think it's 3.5, you should do imaging. Like, our eyes are good up to probably 3 millimeter vessel size to say, which stent is going to be appropriate, and you can always post-dilate. But if you think it's going to be 3.5 or bigger, please image, because you will be surprised multiple times.
Hi, everyone. As a non-invasive cardiologist up here, I just wanted to add that, of course, I do believe strongly in the power of imaging, but I also believe in the power of equipoise. So you don't have to do something just because you can. And especially now in 2025, we'll hear a little bit later this morning about how we can change the plaque phenotype through medications. And so imaging the plaque and understanding it and really deciding, does it make sense to stent it now, or does it make sense to maximize preventive medications and come back to it? I would also implore us to think about that as well.
All right, any other comments?
I do have a question, actually. Can anybody on the panel, anybody practice has changed based on Eclipse data? Because I feel like in terms of practice pattern for calcium modification, our practice has changed more with the intravascular lithotripsy being available in the market. There is some data that how we are using less and less atherectomy and more and more lithotripsy. But anybody's practice has changed based on Eclipse trial? We haven't seen that in our institution, so I'm just curious to know.
All right, we're going to now do our next two presentations are cases, and we're going to do the best case of the past year, and this is Konstantinos Charitakis from University of Texas.
Thank you. Oh, yes, that's true. Maybe the clicker. Yeah, thank you. I'll take that. Good morning. I would like to thank Manos and the team for inviting me here this year. Fantastic conference as usual. So it's always hard to present, your best case. It can be just a simple one that you stent balloon rotor out. It has to have some drama. So this case was a case that I did earlier this year. I have no disclosures relevant to this talk. The reason this patient came to the hospital was for exertional chest pain. He's had it for a couple of months, but for the last 2 weeks, it's getting worse and worse. 63-year-old, he has history of stroke, but very functional, drives, goes everywhere. He has history of PCI in the past. It was an proximal LAD in 2015. He has known ischemic cardiomyopathy. We found his echo from a prior admission to the hospital. He's end-stage renal disease on peritoneal dialysis. He has diabetes, hypertension, hyperlipidemia, and severe peripheral vascular disease. So his blood pressure was okay, heart rate 90. Troponin at presentation was 10,000. And the first thing we do, we get an echocardiogram. His EF was dropped 10 to 15% with global hypokinesis. So we go straight to the angiogram. We went femoral axis, he had prior fistulas. And pretty self-explanatory. You see the proximal LAD disease. I don't know if I can go back and show it one more time. But pretty self-explanatory. You can see the proximal LAD disease. Some collaterals to the right, but the RCA is CTO. So we proceeded at this time. We knew who was the culprit. However, we wanted to see if there is viability or not. I'm sorry this, doesn't continue to play. But you see the MRI severely reduced. I'll go back and maybe try to go forward one more time. So you see severely reduced LV function, in the presence of the left ventricular clot. So the report came back as viable myocardium in the anterior distribution, but circ territory and RCA territory basically scar. Apical thrombus is noted, and the question is, how do we move forward? We know here that he's 63, functional guy, EF is 10%, he has an LV clot, he has severe peripheral vascular disease with chronic disease of the right coronary. The severe LAD disease you noticed, but the anterior territory is viable. And we call the surgeons. Surgeons said that too high risk for us. He's never going to come off the pump, or even off pump lima to LAD. He's never going to be able to get it. So maybe I'll take a break here and ask the audience how to proceed. The clinical challenge that I faced in this patient is he's a patient that we want to help, but are there good hemodynamic support options? Do we need hemodynamic support? He's not an ECMO candidate because of peripheral vascular disease. We call the heart failure team, a questionable candidate for advanced therapies. He's not an Impella candidate. He has the LV clot. Do we even put balloon pump in or not? Maybe I'll open it to the panel experts and to the audience. What would you all do?
Okay, nice case. I think all the questions are very valid. I'm not entirely, so I would do a right heart cath to see whether or not you have to do this with support. The other thing is that the lesion, you said a simple plan, the lesion is short. The ischemia time is not going to be very prolonged, so maybe you can get by without having to do support. You probably have to rotablate, but if you rotablate or you do rotation ablation, whatever you choose, it's going to be a short one. So I think you can get by as long as the patient is not in the compensated heart failure.
Actually, I should have included the data, but his wedge was 28, cardiac index was 1.4. So after that, we took 4 days diurese the patient. So we did that, yes.
Yeah,
he definitely was a guy that needed some support according to the data.
That's an important aspect.
I've been increasingly more disillusioned here in our efforts for percutaneous revascularization in these patients with severe LV dysfunction. This is a little bit of a different case from something like BESIS Revived, but it really level sets what are objectives for the patient and the discussions with the patient and their family. When there's proximal LAD disease or left main disease, I think it's a different issue, but the viability really hasn't guided us in improving LV function. This type of patient wouldn't be enrolled in a trial like BESIS, presenting with a non-ST elevation myocardial infarction. So I think it's a different strategy, but when we looked at quality of life in the Optimum trial of more than 700 surgical turndown patients, completeness of revascularization, which is seemingly always our endeavor, really didn't influence quality of life or self-reported health status metrics. And so, the question really becomes, are you striving for completeness of revascularization in a case like this, or are you going to do more targeted revascularization to think about perhaps improving prognosis for left main or proximal LAD disease?
Yeah, thank you. Both great points. The right heart cath was done, and it did show that the patient needed some support. However, I named this a simple plan because my plan was simple: in and out. I don't know if you guys have seen this movie, great movie with Bill Bob Thornton. They find like $4 million in a crash plane, and they say, you know what? We'll keep the money. We'll stay quiet. And 6 months later, we'll start, going through them. Unfortunately, it didn't work for them that way, and my simple plan didn't work that great either. So, you see here that the balloon is not giving, and you see that, the lesion, is pretty much the same. I tried all sorts of balloons. Every time was going up, the pressure was going down. So, I had to be quick. So I said, maybe I'm not going to rotablate. I'll try to see shockwave. So, this was shockwave. It looked better, but, you see immediately after, I get this like no reflow. However, whenever I saw that picture, I said, I'm doing something different than all the balloons I've tried so far. I asked for a non-compliant, give me a 3-0 non-compliant balloon. I'll balloon this quickly, stand it, and get out. I don't know if you guys have ever seen this screen while you're doing an angiogram. At this point, I get the death screen. An error has occurred to continue, reboot your machine. So at this time, I'm right there, the guy no reflow, and I said, well, should we move to a different room, or this is something you can wait? So they said, well, you have 12 minutes here to do the heart reboot, and that's what we're going to do, because there is a lab available, but it's going to take more time for us to move from here to there. Obviously, at this time, what do we know where we're standing? The lesion, more complex than initially thought, required a shock wave, LAD shuts down, and unfortunately, the X-ray machine shuts down. 12 minutes for reboot, and in a couple of minutes in this, the patients are having chest pain, VT, losing pulses. And we started like 10 minutes of CPR, multiple shocks, maxed on 3 pressors, inotropes. We intubate, and we call the heart failure team that saw him before the case. And obviously, the people said, listen, this guy was not an ECMO candidate before. He's not going to be an ECMO candidate now. So do what you want, think it's the best thing for you. But if you're going to put an impella, he has an LV clot. It's your own risk. So I'll take a break here. What are you all going to do?
Yeah, obviously you really don't have a lot of options. Probably just, if you get pulse back, put on a vasopressors, and hopefully your X-ray machine is back up, and balloons if you can restore a flow. One thing that I would like to make a point is, it's always, we try to do these kind of cases, and we try to talk about also always having a bailout backup plan. Usually if you don't have a bailout backup plan, I would personally not have done this PCI without hemodynamic support. I understand he didn't have a great endovascular options, but you can find a center where they can do transcable for ECMO cannula and all that if we were going to revascularize this patient. Because situation like this, we can try to do in and out, but at the same time, you don't really know until you're actually in there whether it's going to be in and out or not. And this is a great example of that case.
Excellent point, and that was exactly my thought when the machine shut down. Yep.
Yeah, so actually before you start with your procedure, I was thinking, impella is not an option, you don't have ECMO. Balloon pump is not enough to help with your index, but it helps with your coronary perfusion, especially in this kind of scenarios that you may expect no reflow, you have the RCA CTO, you're really hanging by thread here. So I wouldn't hesitate to use a balloon pump from the other groin and just have something in place, And that sometimes is all you need. It may not be sufficient again for index, but for coronary perfusion, that might be a good idea.
Thank you, excellent point. And obviously we thought about that too. We had the access on the other groin. We never, put it from the get-go, but we thought for that too, yes.
Yeah, you didn't have a picture of left groin, but the right groin, looked tortuous, but did look like it was big enough to take a ECMO cannula also. So I would have personally done an upfront ECMO-assisted PCI and then give him the best chance to recover.
Thank you.
But I do understand the complexity of how
Yes,
if advanced heart failure says not an ECMO candidate, then you are kind of stuck.
Yeah, I think upfront is the key, though, right? It's once you're trying to salvage, that's a difficult situation. It's always better to have support of some kind. And I guess tandem would not have been an option here.
We do tandem in our institution,
Yeah.
yes.
So somebody like this with an EF of 10, as much as it looks like a simple lesion, but it's calcified, and he doesn't have much else going. So I think I would do this up front. Tandem balloon pump still works. I don't know how tall the gentleman was, but you can go up to 50 if they're tall enough, and that gives you a lot better support. But up front, I think, is the key.
Thank you. Yes, all excellent points, and obviously at this time I also thought, I wish at least I had put the balloon pump in, and at that time, those 10 minutes of CPR, I obviously felt that, so what I decided to do was I'll take my own risk, and I'm going to put the impella in despite LV clot. I thought that at this time, no ECMO, no tandem, the advanced heart failure were, very reluctant to do anything, and you see the lady is shut down completely. So what happened is, very, with just a simple, a 3 or 3.5 balloon up a couple of times, I was at the end, and everything looked pretty good. Obviously, we have an impella in. At this time, the patient is intubated and on multiple pressors. You'll see the shot that I took from from the, maybe it will play now, I hope. There was basically completely, obstructed flow down the leg. So, and on the right you see we did an antegrade, stick, and we connected from the other side for perfusion. I'll go a little bit forward because it looks like we're, timing-wise. So pre-Impella, obviously, on multiple pressors. Post-Impella, improved perfusion, the vasopressor dependence and the lactate came down. So it looks like I was able to get him off the table, go upstairs in the unit and see how it goes. Well, unfortunately, the drama is not ending. Later that day, he lost completely peripheral pulses. His left became cold, and despite the antegrade sheath, lactate going back to 6, ongoing vasopressor dependence, not able to pull volume on CRT. What do we do? I think I'm going to go forward. We call the surgeons. The surgeons were very reluctant. They're like, it has an LV clot. We cannot upgrade. Usually, we never leave an Impella CP in for more than 24 hours. We're big into upgrading to, Impella 5 as soon as we can. And after a lot of discussion with the surgeons, they took him. They upgraded the Impella from CP to 5.5 from the right axillary. His pressures became better, lactate came down, and within 48 hours, he came off pressors and inotropes in 3 days. So at this point, at least, we have a guy that we can discuss with and see how we move forward. The resolution of the challenge, advanced therapies workup was initiated. He did inpatient rehab with Impella 5.5 in place for 3 weeks in the hospital. And because he was end-stage renal disease, he underwent heart and kidney transplant 3 weeks later and left the hospital close to 2 months after the initial PCI. Pathology of his heart, 315 grams with multifocal LARs of fibrosis and scar, and at this point, non-obstructive LAD disease. But obviously, and I'm curious about your opinions. I'm curious how much his cardiomyopathy was, ischemic mostly or mostly non-ischemic. The key learnings for the operator and the team, a plan, unfortunately, is very simple, as the excellent comments that Joel made about, you think that you're going to go in and out quickly, but, unfortunately, that's not always the case. A multidisciplinary team approach is crucial, and determine eligibility for advanced therapies or devices, as you mentioned early. But this was definitely a lesson for me to plan in advance. Thank you.
It is true, plan is frequently not simple, but I think the challenge in this one was you're losing your x-ray. So with shockwave and then the LED closed, it's not usually because of slow flow or distal, it's because of local dissection. And if you actually had x-ray and could have actually blown up a balloon, got flow, done an auto perfusion balloon, and had flow to LED, you wouldn't have had to go.
Right. That's what I was going to say,
Not
Tim,
only did the
as well.
support ultimately help you, but unfortunately it created problems down the line, which is the downside of support, right? Limb ischemia, bleeding. And so it's the biggest problem here is losing x-ray for 12 minutes.
You're correct. I don't try to defend myself, but actually once we got x-ray back within like 5 minutes, we had flow back and it went pretty fast after that. So definitely the guy that did 12 minutes of CPR did not help him, yes.
All right, we'll have one comment in the back, then we're going to go to the next case.
That's a good point. I mean, we have aspirated, many times clots or vegetation from the right side, but and I have seen in conferences about people aspirating from the LV, but in our institution, I don't think we've ever had a case done.
All right, well, thank you very much. That's certainly challenging. And our next one is the case of the past year that taught me the most, and this is Assad Nakhle from Henry Ford.
Hi, good morning. Thanks again for the invitation, and I'm just going to go through the case quickly to get back. I have no disclosures about this case. Our patient is a 65-year-old male. Basically was referred eventually to us at our hospital for worsening dyspnea and exertion and angina. He has a history of hypertension and hyperlipidemia. He went to a different hospital, outside hospital. They started the workup as an outpatient. EF was 40-45%, no significant regional wall motion abnormalities, and no valvular issues. So the cardiologist who saw him initially proceeded with a coronary angiogram. And here are two pictures, basically with a large dominant RCA with a significant lesion in the middle, and then an LAD CTO. So they called us, asked us if we can do the LAD, and they will start with the RCA PCI, which after the patient obviously declined CABG. So the referring physician performed the RCA PCI and then sent him to us for an LAD CTO. So this is our setup shot. We almost always go by femoral, 8 French, 45 centimeters, and then we had an antegrade sheath that was 8 French, and then a retrograde, which was 7 French. The CTO didn't look that bad, to be honest. I mean, if you calculate the JCTO, it's probably a 0. I had a interventional fellow with me who I felt comfortable with him trying it because I thought it's going to be easy, quickly antegrade wiring, and he'll be done. His blood pressure, the patient's blood pressure in the beginning of the case was 190 to 200, even when he checked in. So he was continuously hypertensive. So first 2 wires, polymer jacketed, quickly ended up subintimal. We tried parallel wiring, trying different wires with the Gaias, with wire escalation, trying to find a different channel, or the true channel. We couldn't. And then with the retrograde injections, we didn't see a good quality filling all the way back. That ADR was not really appealing at this point. So we decided to try retrograde, and we tried really hard. Like I tried surfing all the septals. You'll see here in all those pictures, I'm taking tip injections from all the branches, including the distal apical LAD, the septals, the RPL, and even went into a marginal branch to see if there's any connection to the LAD. We just couldn't make any connections. So went back, tried to take a retrograde picture to see if we can go back with ADR. Still, the LAD is not really filling very well. But I saw maybe at the apex that there was a possible connection here. So took a tip injection, tried to clarify the course of the vessel. Suo, Xian black, nothing went. And at some point, the Suo probably spinned it too much, and when it buckles on itself, and I was pulling it into the microcatheter and kind of, I felt a tug. At this point, the patient became very restless, and if you look at the screen, there was tombstones, ST elevations of the anterior leads. So we kind of figured out that because of losing the flow in the LAD, he was basically having an interior MI. We took a retrograde picture. There's absolutely no filling of the LAD. And then I took an antegrade puff to see what we're dealing with. We kind of knew that there was probably, the wire was subintimal, just the hematoma propagated into the LAD and just lost flow in the whole vessel. So at this point, I called for help. Luckily, my help is Cal Al-Aswad, so I know I'm fine. So I started the LAD just to restore some flow, ballooned the whole LAD, and I started the diag, which was the only large diag that we appreciated, and we did restore flow. So these are pictures. TIMI 3 flow, to our surprise even. The septals are fine. So the septals, the diag, everything is good. The ST elevation resolved. The patient's blood pressure at this point was 130/70. So something is different. He was very hypertensive in the beginning. It's not like we gave like intravascular nitro or treated the high blood pressure. So looking back at the pictures, we saw a distal apical RCA perforation. So quick bedside echo, we saw large pericardial effusion with tamponade. So we did a pericardiocentesis, ended up wiring that branch again and putting a small balloon, a 2O balloon. And you can see the guide, although here it was very deep engaged, even the 2O balloon kind of got pushed the guide out, and it was difficult to advance. At the same time, while we had this balloon up for 20 minutes, we decided to just stent the entry into the CTO to make our job easier the next time. So rewired the LAD. We possibly saw some staining here, so we were like, all right, let's also put a balloon there and just leave it up. So after 20 minutes of balloon up, there was still extravasation. I don't know if you can see it very well here. So our options either coil that branch and lose whatever's filling the LAD, or that retrograde filling into the diag, or we can put a small papyrus. Knowing that we couldn't advance the 2O balloon very easily, we used this crossfast. I don't know if people have it, but it's a really nice guide extension catheter that comes with a dilator and basically goes over the 014 wire immediately without having to anchor or to inchworm. So it gives you the benefit of being able to push the guide liner very quickly and then prevents injury to the whole RCA and the PDA to get you there. So with the crossfast, we were able to put a 2.5 papyrus, inflated it at low pressure just to expand it, and that really controlled the bleeding. So this is the final picture of the RCA. You can see the papyrus is fine, and there's no bleeding. And then the LAD and the diag are still open, TIMI-3 flow, and with the septals. So the plan is to bring him back in 8 weeks. Unfortunately, this is coming in 2 weeks to finish the CTO. So what did I learn from this case? A few things. I mean, antegrade wire escalations, especially when we're starting to learn CTOs, yes, it can be simple and quick, but occasionally it doesn't come without risk, right? So a simple antegrade wire escalation, we think it's going to be 5 minutes CTO, just wire, balloon, and IVUS and stent. But in this case, we lost the flow to the whole LAD, and we had to salvage it. So having a proctor in the beginning of of people learning CTOs, or being comfortable with techniques that can bail you out of trouble. Always control the subintimal space. I don't think about it with antegrade wire escalation, but if I dissect antegrade, you have to control the subintimal space. In this case, I think the blood pressure, the very high blood pressure, did not help and kind of propagate the dissection down the LAD. Tamponade is not one of the guideline recommended therapies for hypertension. So if your blood pressure was very, very high and now is normal, that doesn't mean the patient is fine. In this case, the tamponade was evident. The crossfast is a new tool, and it's kind of, I think, helped us a lot in a few cases where you have to just put a guide liner. You don't want to risk damaging the vessel, or you don't want to risk having prolonged between anchoring or inchworming to get the guide liner all the way down. So it can help in those situations. Always ask for help. My help is really good, so I'm lucky with that. But I think even very advanced operators, if they have a complication, I'm sure they would appreciate somebody next to them just to make things quicker. And then because of the title of the session, I added that the patient is on high-intensity statins. Thank you so much.
Thanks for the presentation. Any comments or questions, very briefly?
I mean, great case. One thing with perforation, I think is very important is to, when you see it, you believe it and you act on it instead of going and take a lot of time to go through the grieving process of denying, and that's nothing. Take more pictures. When you see it, I think the sooner you act on it and get the pericardiocentesis tray and echo and balloon tamponade, I think the more success you will have.
True, I agree.
So I give you kudos for allowing the fellow to start the case, because that's always hard for a CTO. So I'd like to know what the wire sequence was there, and then obviously, one of the points is just the meticulous, slow, beginning of a CTO, because once you get, in the wrong spot, it can go downhill quickly.
Right. So I thought at the time it's a very tapered entry in the proximal cap. It's a very short. I thought we're just going to use a Fielder XTA and try to find a microchannel and just be done. The Fielder XTA was the first wire to go subintimal. I tried with a more penetrative polymer jacketed with a Raider wire, and that kept following the same track, could not find a different track. I tried Gaias to try to be able to redirect them, tried parallel wiring. Unfortunately, I think that hematoma that started because of his that propagated because of his very high blood pressure made the subintimal space really large. Obviously, we didn't recognize it in the beginning because you can do straw and try different techniques, but in this case that's how it progressed.
How was it ultimately crossed?
Star. So we ended up, when we lost the flow into the LAD, we just start into the LAD and the diag because of the ST elevations.
You know, as a final comment, one of the most educational aspects of a case like this is not only learning for yourself as you evolve in your experience in your career and your colleagues, but really to take advantage of interventional meetings, group meetings, M&M meetings, to share these types of cases with others, so that it's not just you and, for example, Cal, who experienced this, but you know how others can learn from it too, because this is really the advantage of best practice sharing and taking advantage of, you know, for those that don't have quality meetings in their interventional programs. You know, sometimes we get so focused on the administrative issues or looking at our outcomes, our metrics, but not taking time to share cases like this of how you and your colleagues work through something as well.
I agree. I mean, sharing a successful case is nice.
Yeah.
And it's satisfying, but I think you learn more from those.
Yeah. Well, thank you. We're gonna. Oh, John,
Can
go
I
ahead.
just ask, would anybody have used something other than the papyrus for that distal perforation? I just want to hear other experience approaches.
Yeah, but I would have probably just coiled that, but if we can deliver a papyrus exclude, it's not, I mean, it's a two vessel, so it's probably going to close at some point anyway, but I would have personally coiled that.
Right, so that was my plan. Again, that's why I said Cal was next to me, so he's like, let's try to put a small papyrus, and if we have a problem or we can't seal it, you can always go back and coil it. And we were assuming that it's going to close eventually, right? But at some point, if it narrows, it might grow collaterals backwards. I'm not sure how big of an area it is, but worth trying.
And
We're going to transition, just to keep us on time, to Tim Henry. So a bit of a change up in our schedule. Mauricio Cohen's going to address PCI guideline update in our next session, and along with ACS guideline updates. And so Tim is going to address the future of refractory angina treatment. Thanks, Tim.
So I guess we're going to continue in talking about challenging cases. And so in terms of disclosure, I don't own anything, but involved in a lot of trials and currently national PI for both the Coronary COSIRA 2 shockwave trial as well as the EXACT 2 Xylacro trial, which we're going to talk about. So I asked this yesterday, and I think when you see people who have refractory angina, why are they having chest pain? And I think it's really important to consider this situation because you have epicardial disease, you have microvascular disease, and you have vasoconstricted disease, and it frequently goes together. We think of them as separate, but many of these patients have more than one effort. Another really important point, this is from a refractory angina paper that we had a couple years ago with the Italians, and it's really important when you think about chest pain is the heart-brain connections, which is very, very complicated. And I will tell you, when you take care of these people, these are people who have lots of pain. And then there's lots of other people who, you know, close their LED and don't have any chest pain at all. So this nociception, this issue of how people perceive pain is a really important issue as well. I'd point people to, we just had a new paper, brand new paper that I think state-of-the-art for refractory angina in the European Heart Journal that just came out last month. And in particular, I think it sort of codifies for the first time that patients who have microvascular disease or non-obstructive coronary disease but severe angina are refractory angina patients as well. And so I think it's a really nice paper if people want to take a look at. And I like this diagram because this illustrates in many ways how you can have severe chest pain. In terms of patients with obstructive patients, you can have severe restenosis, you can have diffuse disease, but in addition, you can have microvascular disease or vasoconstriction disease on top of it. And in terms of the microvasculature, it's not just spasm, but it's myocardial bridges, et cetera. So this is frequently very complicated about why does a patient keep having chest pain is not a candidate for revascularization. We've tried to simplify this and put this in 4 different patient categories, and you can see we did this about 10 years ago with Mark Jalcour, and in phenotype A is the ANOCA-INOCA patient. Phenotype B is the sort of the multiple CTO patient, and we've done a really good job of that. And then phenotype C is the type 1 or type 2 diabetic, which has diffuse distal and side branch disease, and there's just really nothing you can do about it. And then phenotype D is the patient that you come in and you say, I've had 69 caths and I have 32 stents, and I've had 3 bypasses. And it's really just end-stage coronary disease. And the good news is we've kept all these people alive. And I think this is one of the things. People used to think these patients were high risk. But with good risk factor modification and medical therapy, this is actually survival in our Optimist clinic, which is our refractory angina clinic when I was in Minneapolis Heart. And it turns out mortality is only about 2.5%, 3% per year, which is the same as age-matched controls. So this is a quality of life problem. It's typically not a dying problem. And another issue is we call these no-option patients because there's no candidates for revascularization. But it's very important to look at their last few angiograms and say, is there an area that could get worse? So when we looked at it, despite being no option, in clinical trials and in our registry, about 25% of people have subsequent revascularization within the first 2 years. Why is that? Well, it turns out 48% were new lesions. Either they developed restenosis or had a very common one is progression of disease in an old vein graft. 33% of patients, you just were forced into doing something something you didn't want to do, and in many cases that does not go well. So what do you do? So we have had a refractory angina clinic for almost 25 years, and I would really encourage those of you who have large groups to do this. There's a huge number of patient populations, and for example, since I got to Cincinnati, we didn't have a program. What we did is we've developed a women's heart program. Despite 5 practitioners, there's a 3-month waiting list to get in. I have over 30 consults with refractory angina waiting to be seen. Our CTO volume has gone from 150 a year to this year we'll do 350 CTOs. So there's a huge unmet need out there, and if you actually build it, trust me, they will come. But what we do with everyone is optimal medical management, look at risk factor modifications, and review their revascularization options. And then we have all the kinds of sort of clinically available and research things available for patients. And our goal is to find something that makes people better. And now we've done this 2 different times, and in a dedicated refractory angina clinic, we find at the end of 1 year, 90%, 85 to 90% of patients have had a significant improvement in their angina because you can find something that works. So I'm going to go through, first of all, EECP. Lots of people don't have it available, but it's very useful both for microvascular disease as well as refractory angina. It's indicated for class 3 and class 4 angina. You do 35 treatments, 5 days a week, 5 times a week for 7 weeks, or you can do it twice a day. But it's a very important thing to have, and it also is effective in microvascular disease. CTO PCI is a critical part of a refractory angina program. So we work very closely. Jared Frizzell is our CTO guy. We look at 5 to 10 cases a week and say, what can we do from a revascularization standpoint? So it's critical part of a refractory angina program. And those of you know you have great success. But even when you have success in CTOs, about 25 or 30% of those patients have persistent pain. And much of that's related to microvascular disease. So what about cell-based therapies? There's actually great data that showed that CD34 stem cells, 3 consecutive double-blind placebo-controlled show improvement in angina, improvement in exercise time, reduction in mortality. Fortunately, it's not available, and it's got to do with the business plan. It's just too expensive. But there is things available. This is actually an ongoing cell therapy trial that's available where you actually pull out CD34 positive cells in the cath lab and then do direct intramyocardial injection. So that trial is still going on. And more importantly, what I'm excited about is From a business span, gene therapy has progressed significantly. We have now better vectors that are more designed, cardiotropic vectors, and then we have better gene products. So for example, this EXACT-1 trial was just published in Circ Interventions that showed significant improvement in phase 1 when it was delivered with a mini thoracotomy. But instead, we're now doing it intramural. We did the first cases in the world 2 weeks ago, where we do intramural injection using a new endocardial needle. So this trial is ongoing. We'll randomize patients to gene therapy versus placebo. And what we saw in the first trial was improvement in exercise, reduction in angina, improvement in PET score. So it's something to think about. The next thing I'm going to talk about is this combination of epicardial disease and microvascular disease. So these are patients who had refractory angina. It comes from the Beck trial. So a long time ago, actually, back in the 1960s, he closed off the coronary sinus. And when you did that, it changes endocardial to epicardial flow. So what came out of this is bypass surgery came around, and so the Beck procedure is gone. But now what we're doing is we have the coronary sinus reducer. So this is an hourglass-shaped stent that you put in the coronary sinus. You develop restenosis, so there's an outflow gradient, and that gradient, probably two mechanisms, but the one is you change endocardial to epicardial flow and restore it to its normal level. This is the data. It's a very simple procedure. We've done over 50 now. It's approved in Europe, and they've done over 5,000 in Europe. And it takes about 35 to 40 minutes. This was the CVI trial published in New England Journal. It showed significant improvement in angina and also improvement in exercise time. Second randomized trial was the Orbita Cosmic trial presented last year that showed a significant improvement in angina in the coronary sinus treated patients, and again, a double-blind placebo-controlled trial. And they showed no improvement in transmural myocardial perfusion, but a significant improvement in endocardial perfusion, which is what we expected. There's also a registry that shows the same thing, that about 75 to 80% get better. So this is the ongoing clinical trial in the United States, which is COSIRA-2. So if you have patients with severe epicardial disease, then think about it, send them to a site that has it. It's randomized 1-to-1, class 3 and class 4 angina, to either the coronary sinus reducer or placebo. And then there's a chance for crossover at 12 months. More importantly, there's 3 registries that are available. Patients with primary RCA ischemia, patients who are unable to walk on a treadmill, and patients with microvascular angina have the opportunity for crossover. There's also shockwave therapy, not available in the United States, but in Europe, and it actually shows progress where you do a serial echo guided. It's sort of like external beam shockwave, which has shown some support. So, just for the record, these are patients who CABG didn't work, PCI didn't work, tender loving care didn't work, and medical therapy didn't work. So they are challenging patients, but we have a lot of things available for them right now. And if you have patients who have refractory symptoms, get them to a place you do it, because there's a wide variety of therapies that will work. And I think in the future, we're going to have something for everybody. And I'm personally excited about it. And the last thing I'll say is, this is a team sport. So we have our CTO, which is Jared, myself, Odami Casada from the Women's Heart Clinic. We have an endocrinologist that we work with because we work very hard on their risk factors. We have a nephrologist that we work with and an anesthesiologist that we work with. But with that, you can make the quality of life better. Thank you very much.
Thanks, Tim. I want to open this up to our audience and our panel for comments and questions, too. Tim, let me begin by asking you, you've taught me a lot by visiting your program about microvascular angina and the studies that you're looking at for angina without epicardial coronary disease. So in the absence of identifying it in those particular patients, how do we diagnose refractory angina in some of these patients? Because, you know, is it imaging? Is it PET imaging? Is it invasive studies? Or ultimately, is it just a good clinical judgment that this discomfort in your chest is your heart and it's not something else?
Yeah, so that's a really important issue too. And I will say that, first of all, to get into the clinical trials, you have to have documented reversible ischemia on an imaging test. But one of the problems with this and using it as endpoints is, you know, imaging works if you have a 95% proximal LAD. But these are patients who have multiple, you know, an occluded diagonal, an occluded OM. You know, usually they have evidence for ischemia in all three vascular distributions. In addition to a high number of them have microvascular disease. So imaging is much more challenging. Now, we're doing new stress PET, and in the Xylacor trial, the stress PET worked well. The problem is the ability to do good stress PET is not available at most sites around the United States. It's really very specialized places that can do it well. So the ability to image is still a problem.
Got it.
Great team with your excellent program. You talked about it yesterday. The CTO, you know, subset is, I think, the most challenging one because, as you said, about a third of them they still have chest pain. In your experience, is there any way that you can have some prediction which patient? I know it's a tough question. And second, from my understanding in Kondzari, because we are actually becoming a site, if somebody has a CTO, can be eligible for the trial. Is that right or not?
Yeah. So this is a really important thing for all of you that do CTO over out there. I think CTO, PCI, and refractory angina clinics go hand in hand. And I can tell you with Jared and myself, it's worked tremendously well. We always review cases and say, is there a chance at revascularizing it? But now, if you've had restenosis in a full metal jacket in the right coronary 3 times, you know, there's a limit of what you can do. And also, there's patients where you do as well as you can do, and they still have either diffuse disease or they have microvascular dysfunction as well, so they're still having angina. So we find this incredibly complementary. And I think the places that are doing really well enrolling in the trial are those patients that have their CTO expert is very much involved in the procedure itself. They're not competing, they're complementary.
Perfect. Tim, thank you. And just to keep us on time, we're going to, I won't say change directions because pharma and devices travel the same path here, but turn in a new light here with Payal Kohli to address lipid management for us. Oh, did you have one other comment?
Yeah.
I'm sorry. Before we go, sorry, Payal.
I just want to ask about
something
I have read in your paper that's published in 2021, which is transmyocardial laser revascularization. Transmyocardial laser revascularization in cases of refractory angina. I heard about that, but I didn't get it.
Say that again. I'm sorry, I couldn't.
Yeah, transmyocardial laser revascularization.
You know, so I didn't go through all the things out there. You know, there are a number of other things. TMR is still available as a standalone. We actually did it in a randomized trials, endocardial, and there was no benefit, and there was a little higher risk. But as an adjunct to surgery, it's still being done a few places in the United States, but limited.
What about ultrasound treatment of refractory angina?
Say that again?
Ultrasound treatment of refractory angina. The ultrasound. The ultrasound.
Yeah, I mean, I don't know that there's any specific from a standpoint in the coronaries, but the shockwave therapy actually it's being used in Israel and Germany, and the early trials are very successful, but they've had trouble from a financial standpoint getting into trials in the United States.
Thank you.
Hello, everyone. Thank you to Dr. Berlakis and the CVI organizers for being here. So my job is to make LDL sexy, right? For a group of interventional cardiologists, what makes LDL sexy? So hopefully you all put your phones down and think about if you were designing a sci-fi movie in cardiology, would you talk about LDL? You just heard about patients crashing, CPR, ECMO, tandem hearts, but LDL is what the sci-fi movie in cardiology is going to look like, and that's what my talk is going to be about today. So I hope that you'll come with me on this journey about when and how to lower LDL in 2025. These are my disclosures, the biggest disclosure being, of course, that I'm a preventive, non-invasive cardiologist. So this is old news, right? The 55 is the new 70? That's old news. Everybody already knows that. What percentage of your ASCVD patients do you think qualify as very high risk? Any guesses? 80? Anyone else? 94%. So pretty much every one of your ASCVD patients, 55 should be the new 70. But I want you to think about 40 being the new 55 in some of your ASCVD patients. Now, which ones are we driving down to 40? The ones that have recurrent vascular events, the ones that are having events despite having an LDL of 55, the ones that have had 2 events in less than 2 years. Because guess what? Their plaque is talking to you. It's telling you it's still angry. So just getting them down to 55 and forgetting about them is not good enough. You need to get them down to 40. So really you need to start thinking about multimodality therapy for dropping your LDL, because we're talking about driving people down to LDLs that they've never really had before. But what about this? Who here thinks about delta LDLs in their patients? I do sometimes, but it's hard to know when they had their vascular event, right? So the guidelines tell us it's not just getting them to 55, it's dropping them by 50%, whichever is lower. So if you have a patient who comes in and has an acute coronary syndrome with an LDL of 70, you're not stopping at 55, you're taking them down to 35. And that's the part of it that we often forget. So remember to look at the delta LDL as well. Okay, now I'm asking you to drop them by 50%. Do we have a single drug agent that can drop LDL by 50%? PCSK9 inhibitors can, right? But a statin by itself, at best, 30 to 40%. So this again sets up the story that we need to start using combination therapy to drive our patients down. If one of your patients came into the office with a blood pressure of 190, would you use a single agent? Of course not. You would use combination therapy. So that's what we need to start doing with our LDLs as well. So you're going to hear from Sunil Rao in a few minutes about the updated ACS guidelines, but here's a sneak peek. A patient hits your cath lab with an angry plaque, you give them combination therapy up front. So if their LDL is greater than 70, that's a no-brainer, right? That's a level of recommendation, class of recommendation 1, because then you got to get it down significantly. But if it's 55 to 69, guess what? They even put that in there as a level of recommendation 2A, that it's reasonable to use combination therapy, where we're talking about a statin and a non-statin option. Because remember, when we stent a lesion, we treat the angry plaque. But what made that plaque angry in the first place? It's that excess LDL. And by lowering their LDL, you're actually starting to change the plaque morphology. So the idea here is becoming that in addition to giving them integralin or heparin or all the other things that you guys give them on the cath lab table, maybe you go ahead and inject them with their first PCSK9 inhibitor, because you start to treat that angry plaque. And data has shown us that if you inject them with that PCSK9 inhibitor, you don't just treat the plaque that ruptured, but you treat non-target lesions. You start to stabilize those as well. So these are our old friends, so I'm going to go through them relatively quickly. We know ezetimibe lowers our LDL 15 to 20%, has outcomes data. We know that evolocumab, alirocumab, we're comfortable with these now. They've been out for a decade. They drop your LDL about 60%. They're injection medicines given every 2 weeks. Bempedoic acid is statin's lazy friend. It's a prodrug that works in the statin pathway, kind of wimpy, drops your LDL 17%. when the statin is around, drops at 22% when the statin is not around, but certainly can be used in combination with the ezetimibe to get about a 38% LDL reduction. And then inclisiran or Leqvio, that's an siRNA, small interfering RNA, drops your LDL about 50%, but mind you, beware, there is no outcomes data yet. It's first time we're using an siRNA in cardiology. So for me, I tend to work on the top two boxes and the left-hand box sometimes if I have my bases loaded and need to bring my man home. These are your old friends, right? You guys are comfortable with them. Now I'm going to tell you what's cooking on the horizon of LDL-lowering agents and what's coming down the line. Have we heard of obicetrapib? Do we know what CETP inhibitors are? So if you dial back to about a decade ago, there was anacetrapib and torcetrapib, right? And they got a really bad rap because we thought we had found the holy grail of preventive cardiology. They dropped your LDL, they raised your HDL, they dropped your ApoB, they dropped all the other remnant particles, and yet they killed people. So there was a higher rate of adverse events using these CETP inhibitors, and that's because they led to sodium retention. So instead of giving up on the entire class of medications, a company called New Amsterdam has redesigned the CETP inhibitor, obicetrapib, which is an oral small molecule inhibitor of cholesterol ester transfer protein. And what it does is it, exactly like I said, it raises your HDL, it raises it by about 135%. It lowers your LDL 45 to 51%, lowers your non-HDL 43%, and it lowers your triglycerides a modest amount, 10 to 15%. So you can have your cake and eat it too, because it doesn't cause sodium retention. It's been safe so far in a whole host of phase 2 trials, and it's currently in phase 3 trials. So now we're talking about a competitor for your Repatha, your PCSK9 inhibitor, or possibly an adjunct, right? Because what if somebody has an event while they're on a PCSK9 inhibitor? Where do you go from there? Well, you start to reach for this. What if you have a patient phenotype that has a low HDL and a high LDL? Perhaps this might be a better option than some of the others. So I'm anxiously awaiting the phase 3 data, but so far this is what we know. And next we have enlicitide. Have we heard of this? An oral PCSK9 inhibitor. It drops your LDL 61%. So guess what? Even though most of our patients are not afraid of injections anymore, if that has been a barrier for any one of your patients, this is not far from coming to approval because the trials so far have been incredibly encouraging. We've had really, really good PK/PD data as well as safety and efficacy data showing no increase in liver enzymes, no increase in CK, no increase in blood pressure, really well tolerated. And it's formulated in a way that makes an oral inhibition possible. Now, as you all know, oral inhibition of PCSK9, just like subcutaneous inhibition, can drop your lipoprotein A as well. So this perhaps might be a better option for your ASCVD patients that have a phenotype where their lipoprotein A levels are elevated. So stay tuned for this to come and get approved pretty soon too. I want to remind you guys of the Fourier trial, which was the trial of evolocumab, because there was an open label extension. So after the trial finished, people were allowed to stay in the study in an open label fashion and get the medication. So you can see the red people there were the ones that were initially randomized to evolocumab and stayed on it, whereas the blue people were initially randomized to placebo and then got evolocumab. So let me point out a few things here. Number one, every single person achieved a median LDL of 26. So at the end of those 8 years, the blue and the red curves are overlapping, right? So both people ended up at the exact same LDL. The red people started earlier, the blue people started later. Second, there was no tachyphylaxis. So you didn't get resistant to the effects of PCSK9 inhibitor. You didn't need more PCSK9 inhibitor over time. And of course, there were no new safety events. So now we have 8 years of data suggesting safe, low levels of LDL in your 20s. But this is what really makes a home run. The people who started early got a head start. So even though they all ended up at the exact same LDL, which was a median LDL of 26, nice and low, earlier is better. And you're talking about a head start with a 23% lower risk of cardiovascular death. So by starting patients at a median of 2.2 years earlier, you give them a death benefit. This is why I want you guys to start treating LDL like an urgent situation, because cholesterol years of exposure are building up. This is not something to think about next visit. This is something that the last 5 minutes or 3 minutes or 2 minutes of every visit, no matter whether it's for palpitations or edema or anything else, needs to be looking at that LDL. And our mantra has become in preventive cardiology, lower is better for longer and faster. So we have to get there faster, guys, because cholesterol years of exposure, just like smoking pack years of exposure, are really adding up. Now, a question for all of you: how do cardiovascular risk-reducing medications alter plaque? Do they have no effect on plaque? Do they increase fibrous cap thickness and plaque? Do they reduce the lipid arc, or do they reduce plaque volume? So everybody take a minute. Everybody has to vote. Who votes for A? Thank God. Okay, who votes for B? Just a couple hands. Lipid arc, C? Okay. And plaque volume, D. Okay. Trick question. B, C, and D. Right? We are changing the phenotype of atherosclerosis. As much as we love to put stents in, you are making it so that they never even need that stent. So they never have that refractory angina. They never have that disease. And how empowering is that? That you're changing a patient's disease trajectory before they even realize it. So really what we need to start thinking about is this, angry plaque, right? And how do we make an angry plaque happy? I always ask a room full of interventionalists, if you could choose between an 80% lesion in your LAD or 20%, which would you choose? 80? Really? You have to pay the mortgage, okay. Well, I would choose a 20. But then if I made the 80% lesion socked in like scar tissue, and I made the 20% lesion angry and ooey and gooey and inflammatory with, necrotic core, suddenly I'm wanting that 80% socked in. And that's what we're doing in preventive cardiology. We're not treating the angry platelet, we're treating the angry plaque, and we're taking an angry plaque and turning it into a happy plaque. And the example that I use with my patients that you're welcome to use as well is a raw egg popping open in the artery. That's what a plaque rupture is. When I give somebody LDL reducing medications, and mind you, not just LDL, I'll tell you in a minute about GLPs and SGLTs and all this other stuff, you're boiling that egg. You're increasing the fibrous cap thickness, reducing the lipid arc. You're actually making the lesion more stable and turning it into scar. So it's not something they're gonna die from. It's something they're going to die with. And to me, that's incredibly empowering as a physician to change their disease trajectory in that way. Now, I've talked to you a little bit about, obviously, where the future of lipid-lowering medicine is headed. We've talked about LDL. We'll talk in a minute about non-LDL targets. But let's switch to the science fiction part of the talk, which is gene editing. Now, CRISPR is a technology that they've now approved for sickle cell anemia. That's the first time they've approved it, where you can actually put a typo in a gene. You can deliver a typo to a gene using a vehicle. So imagine if I could deliver a typo to your PCSK9 gene in your teens and edit your gene for life, so I turn off PCSK9 for life and lower your LDL for life. This is what Verve did, and as you may have heard this morning, Verve just got acquired by Eli Lilly, but they're a startup in Boston, and they looked at 10 patients, many of whom already had pre-existing disease, and they were all patients with FH, of course, and they put a typo in their PCSK9 gene, and look what they saw. They saw a dose-dependent reduction in LDL that was durable up to 2.5 years. Now, why hasn't this made the headlines more yet? Well, because the vehicle that they used to deliver the typo caused problems with liver function tests and platelets, and so they're working on round 2. They're working on a way to deliver the typo to the liver without causing all of those abnormalities. But this is where the future of LDL lowering is headed. Lower for faster, longer, and earlier. Now we're trying to make LDL a quality metric so there can be reimbursements associated with it. We do hope that this will help to fill the gap, but in the interim, I do hope the rest of you guys step up and take this as your personal mission to lower LDL urgently. And try to reach for those non-statin agents early, guys, because using just a single agent is just not the way to do it in 2025. It's medical malpractice, really. Try to not worry so much about the stent and the angry platelet, but actually treat the angry plaque, because you're not just treating the plaque that got angry, you're treating the plaques that are going to get angry, the other non-culprit lesions that the patients have. And of course, we have newer agents coming, so keep an eye out for obicetrapib and enlicitide. And keep an eye out, of course, for gene editing as well. So with that, these are my social handles. Please feel free to follow me if you'd like. But I'm going to switch gears a little bit and talk about beyond LDL. But before I do, I just wanted to open it up to the panel and see if there was any comments or questions, reactions. Please, Henry.
I want to just add for everybody in the audience, the same is true for patients with microvascular angina and vasospastic disease. We really work hard on getting their LDLs ideally under 55.
Any other comments?
Yeah, the other actually point is that while we are treating that patient, as you said, how many years the LDL is high is important. It's best to talk about them, ask their siblings, kids to check their LDL. You will be surprised how many times my patient come back and they're very appreciative, like their 20-some-year-old kid that was doing fine, LDL is like 180, 190. And from all that we learned, the sooner we start is better. So, and then the other habit I got into is check lipoprotein little a on almost everybody I see. Not that we have a targeted therapy now, as you know, lipodystyrene, the siRNA is ongoing trial, phase 3 now, but it's going to come out. So it's best to have the patients who are going to be candidate for that medication already in your system, so as soon as it comes out, you can give, and then use PCSK9 inhibitor, as you said, for time being as a way to address that.
You set me up perfectly for the next talk. Thank you. Yes, but family is our mirror, right? And for every single person in this room, I really, really hope you know your LPA, because 20% of us are sitting here with elevated LPAs, which is a target sign on us for ASCVD, for stroke, for blood clots, for thrombosis, for inflammation.
So, can I ask a question? What should we tell our patients that whenever we drop their LDL less than 40, they come back and say, well, I read somewhere that I need higher LDL for brain function?
Excellent question. Every single primary care doctor I know de-escalates statins sometimes when you get them to these very low LDLs. So here's what I do. I use analytic and non-analytic ways to explain to PCPs and patients. So the first is we have data from the randomized trial, Fourier, a sub-study called Ebbinghaus, where they actually did neurocognitive testing. It's not just, I feel more foggy, but they actually had them do formal neurocognitive tests, mind you, with a median LDL of 26. And there was absolutely no difference. So that's point number one. Point number two, low LDL causes strokes, right? It causes brain bleeds. If you look at the Fourier trial, there was a 21% lower risk of stroke, including ischemic and hemorrhagic stroke, not higher, with driving your LDLs down. So for the PCPs, that's my analytic data that says, okay, the lower, we have randomized trial evidence to tell us that the lower LDLs are not dangerous to our patients. For my patients, I actually ask them, what are the 3 things that you fear the most as you get older? Because we all fear aging, right? But what are the things we fear the most? What do you guys fear the most? Stroke, number 1. Number 2, dementia. And number 3 for men, erectile dysfunction, right? So I tell most of my patients, I can reduce your risk of those 3 things, vascular erectile dysfunction, vascular dementia, and stroke, substantially if I keep your LDL below 70 for most of your adult life. And we've seen all the data out there that stroke actually goes down, not up with lower LDL. I do also explain to them the analogy of where this data came from, that too low is dangerous, and it came from the 90s, where we were putting patients on statins that had very low, that had had strokes, and that had had dementia. And so it's an association, not a causation. It's sort of like saying that, statins cause gray hair. No.
What about diabetes?
Diabetes. So there is absolutely 100% a dose-dependent increase in diabetes that occurs with statin therapy. It's a little worse in women than it is in men, and it's worse in pre-diabetics and obviously patients who are already diabetics. But having said that, this is what I generally tend to do, is if I'm in the right class of medications, meaning I'm already on Rasuva 20, I probably won't go to Rasuva 40 and cause more of a bump in the A1C. Instead, I'll reach for combination therapy. And of course, we know in our diabetics that they have a high risk of reduction, a 22% reduction for every 39 points I drop their LDL. It's a good point.
Payal, let me just interrupt you too, just before we transition.
Yeah.
You know, as another aside, I tell my patients that when they're born, their LDL is about 5 or 10. So you don't need a high LDL for good brain maturation and growth and development as well. That said, though, this is maybe going to lead you into the next lecture as well, but since you raised it with LDL lowering and HDL raising, let me ask you, is there a purpose for HDL raising?
So we don't know the answer yet. I
Yeah.
mean, pharmacologically, obviously, we know from AIM-HIGH and other trials that thus far it hasn't worked. But the CETP inhibitors are hopeful that some of their mechanism of benefit is through LDL, some of it is through LPA, and some of it is through HDL raising. But we haven't been able to accomplish it in a pharmacologic way that offers cardiovascular risk reduction. Vasipa, I'll talk about that in a minute. Yes. Any other questions? Okay,
Last question. Can I just ask one thing
Yeah.
here? So this may lead into your next talk, but does all mechanisms of LDL lowering, are they equivalent? And you know, if we're really using LDL in some way as a marker of inflammation, right? Does the manner we get there matter? Should we be?
So are all mechanisms of LDL lowering the same? Great sophisticated question. The answer when it comes to plaque is yes. So it doesn't matter how I lower your LDL, I will increase your fibrous cap thickness, reduce your lipid arc, and reduce, you know, your necrotic core. But the degree of how much I raise your lipid cap and reduce your necrotic core depends on the degree of LDL lowering. So obviously statins and ezetimibe both work the same way, but Repatha causes a lot more stabilization of my plaque than ezetimibe or bempedoic acid do. Now, having said that, we also know that they work in complementary mechanisms. For example, Repatha and inclisiran work on the LPA pathway of LDL lowering. So that's a different pathway than bempedoic acid and statins, which work in the HMG-CoA reductase pathway and also affect HSCRP. So now you're talking about all these other biomarkers kind of coming into interplay. So sort of yes, they're all the same with respect to plaque, but sort of no, because some reduce inflammation and some reduce lipoprotein A instead. Okay, so with that, I'm going to transition to beyond LDL management in 2025. And this is my favorite talk to give because really, here are my disclosures again, if you need to see them. Really, I feel like this is where we're at. This is me. I'm sitting in my office feeling so good that I've driven down the LDL and the world is literally on fire outside. Because we know that beyond LDL, beyond just getting it down to less than 55, there is a huge fire out there that we're not addressing. In fact, the American Heart Association has coined the cardiovascular kidney metabolic syndrome, which we stage like we stage cancer. And guess what percentage of us in this room have stage 0 CKM? 10%. 90% of us, our friends, our family, our patients, ourselves, are stage 1 or higher CKM. Now, if I told you 90% of the country was stage 1 or higher cancer, everybody would be talking about it. And yet we're all headed for cardiometabolic disease. And the idea here is to start to incorporate this into your everyday clinic. So in addition to writing their pooled cohort estimator score, which by the way, I'm going to tell you to stop using, use the prevent score instead, you're going to start writing their CKM stages onto their patient history, because that's going to help you with better risk stratification. That's going to help you put out the fire outside your window so that you're not just focused on LDL, but you're thinking of all the other target signs out there. So why are we thinking about CKM syndrome? Well, the world has changed, right? We've changed our risk factors. We're heavier than ever before. We're living a lot longer than ever before. We're not smoking nearly as much as we were before. And the type of heart disease we're getting has changed. We're getting more heart failure, and we're getting more stroke as well. We're using a lot more preventive therapies, and we're realizing that the organs don't work in isolation. There are overlapping Venn diagrams when it comes to our cardiovascular, kidney, and metabolic syndrome. So I want every person in this room not to be a cardiologist. I want you to be a CKMologist, right? Because that's the wave of the future, and that's how you're going to change your patient's risk profile. So I'm going to introduce you to the prevent equations. I hope you've used them. They're the newest sort of risk stratification equation, throw the PCE out of the window because it is not relevant anymore. This one incorporates a lot more socioeconomic status. It incorporates a lot more ethnicities. It uses all the traditional risk factors, but it also adds UACR in there. Urine albumin to creatinine ratio, which is extremely important, goes down to the age of 30, and guess what? It adds your zip code. So it tells you if you're from a socioeconomically disadvantaged status. It's calibrated to the lower event rates that we're having now. It includes stroke and heart failure as opposed to just MIs as before, and it doesn't overestimate risk nearly as much as PCE. So PREVENT is the new PCE. That's the equation that you guys should be using in everyone, and you should be placing it in the context of their CKM stage. So the first thing you do, you ask them about their lifestyle. You check a UACR on every hypertensive, every diabetic, and every ASCVD patient once a year. That is the requirement. That's in the guidelines. So if you're not doing that, write that down because I want you to go back and do that. I could argue that you should even check it in your obese patients. Then you assess their CKM risk using the PREVENT equation. You might throw in a calcium score if it's primary prevention. If they're secondary, obviously you don't need to do that. Then you determine their CKM stage. Then you start to think about your preventive therapies because now you're moving beyond just LDL and thinking of all the things out there you need to do. In fact, these are all our parallel pathways of risk. We have icosapentaethyl, which is our triglyceride pathway. We have lipoprotein A pathway. We have inflammation and obesity, and we have thrombosis. So after LDL, you think about all these pathways. You don't just stop at LDL because then you've done a disservice to your patients. So I'm going to start with the GLPs and the SGLT2s, which are the newest secondary prevention drug. I have friends in Denver who are cardiologists who've never written a GLP. And I consider that medical malpractice because it is a secondary prevention drug. In fact, it's changed the landscape of how we think about CKM syndrome. And the SELECT trial, which was published in the New England Journal of Medicine in 2023, showed patients without diabetes who have a BMI greater than or equal to 27 who got semaglutide. Look what you did to their 3-point MACE. And I want you guys to pay attention to when those curves are diverging. This is really important, right? Because how long does it take for you to lose weight on a GLP? 3 months, 4 months? They're starting to diverge within weeks. 3 weeks they started to diverge. And you're talking about CV death, MI, and stroke, the hardest endpoints we have in cardiology. So you have to really start thinking about the obesity axis for your patients. And we think this may be mediated by inflammation or other markers. We're not entirely sure, but you have to think about it. In fact, if you look at the plaque and what semaglutide does to the plaque, a lot of the same things that LDL lowering does. It doesn't change the volume like LDL lowering does, but it does stabilize the plaque. It also reduces visceral and epicardial fat and reduces liver fat. So again, you're treating that entire body here. In fact, if you look at both GLPs and SGLT2s, we normally think of these as kidney drugs or diabetes drugs. They're actually atherosclerosis drugs now. We know that even SGLT2s have an anti-atherogenic benefit, and this translates into not just decreased kidney outcomes, decreased heart failure outcomes, but actually decreased non-fatal MIs. So now you're talking about GLPs and SGLT2s being secondary prevention drugs for atherosclerosis. We know that GLPs just got a label for kidney as well. And so now you're starting to see these drugs overlap more and more and start to be used. Now, what's the future of GLPs? It's a triple agonist that's coming, GLP, GIP, and glucagon. So the GLP gets 15% of your weight off. The GLP, GIP gets 20%. The triple agonist gets 25%. So I call it Batman, Batman and Robin, Batman, Robin, and Batwoman. So that's coming in the future. We're also seeing a really big shift towards combined broad CKM outcomes. So we're combining our atherosclerotic, our heart failure, and our kidney outcomes so that we can get better insurance approvals for these drugs. And of course, the oral GLPs are coming as well. So that's the GLP SGLT2 pathway, which is the inflammation, obesity. LPA, are we there yet? And you just made an excellent point that we really ought to be checking LPA in every single one of our patients, according to the National Lipid Association guidelines from last summer. No matter what they're there for, you check it once. We know there's a wide variability in LPA that varies by ethnicity. We know that it's 70 to 90% genetically determined. We know it has an autosomal codominant inheritance pattern. And we know that women tend to run higher. We know that LPA is 6 times as atherogenic as LDL, causes MI, causes strokes, causes aortic stenosis, causes pregnancy loss, causes thrombosis, causes inflammation. So why don't we find this target sign and put it on our patients so we can better risk stratify them? We also know that besides PCSK9 inhibitors, which lower 27%, and inclisiran, which lowers it about 19%, most of our agents either have no effect or statins can even raise your LPA slightly. So it is not something we trend in our clinics. The only time I trend it is if a woman is about to get pregnant and she has an elevated LPA going into pregnancy, because we know pregnancy raises your LPA. Then you may want to see how much it was raised. You also want to put that woman on a primary prevention aspirin as well. We know we have siRNAs to reduce LPA. This one is olpasiran, which is an Amgen product, reduced it nearly 100%. And then pelacarsen, which is being developed by Novartis, reduced it about 90% in a dose-dependent fashion. These are probably going to report out in 2026, but we really should be checking it today. Free LPA checking at familyheart.org. So write it down. They'll mail you a kit to your house. Check it for yourself, check it for your family members, because this is what I'm doing different if I find an LPA that's elevated. I move their LDL threshold down. So let's say for primary prevention, my LDL threshold was 100. If your LPA is elevated, you're down to 70. If for primary prevention, my LDL threshold was 70 because you have diabetes or you smoke or something else, I put you at 55. I cascade screen all your family members. That point was also made by our panel. I put a primary prevention aspirin on because we know in the subtype of patients that have an elevated LPA, primary prevention aspirin reduces their risk. So that's another reason to check it. I talked about peri-pregnancy counseling as well, and we know that the trial will report out next year. Okay, next pathway, inflammation. Do we have a blindfold on when it comes to inflammation? Who here has checked an HSCRP? Who's checked one? Okay, great. I'm excited to hear that, but I should see more hands go up because see, HSCRP is the only way we know whether or not somebody has inflammation. In fact, this data from Paul Ridker, if you look at that blue, the dark blue one all the way on the right, you see that if both your CRP and your LDL are elevated, this is in secondary prevention patients, yeah, that's bad. That makes sense, right? But take a look at that second from the right graph. If your LDL is controlled, but your CRP is elevated, that's worse than someone who has an elevated LDL without an elevated CRP. And then if you look at post-PCI patients, which is the ones that are most relevant to you guys, what do you do when you do a PCI? You create inflammation, right? You disrupt the plaque, you pop it open, you release evil humors, you create inflammation. That becomes the tallest bar. The ones that have elevated CRP post-PCI actually have the highest rate of MACE. Now, I'm not telling you to check CRPs post-PCI. That's not the message here, because they're all going to be elevated. But the message here is you should be checking them in your secondary prevention patients. And these are the risk categories. So if you're less than 1, it's normal. 1 to 3, you're intermediate. Greater than 3 is high. And greater than 10 means you need to see a rheumatologist because you've got some underlying systemic thing going on. I check it twice, 2 to 3 weeks apart, to make sure it wasn't just accidentally elevated. And again, I check it remote from their event when they're sort of in a stable phase. Now, here's my caveat on inflammation. If somebody is obese, what do you think their CRP is going to be? High. So make sure you've treated the upstream causes of inflammation before you start chasing CRPs. Treat the obesity, treat the diabetes, treat the CKD, treat the untreated hypertension, all the things that could cause a CRP to go up before you start chasing it. But let's say you've done all that, and then the patient's either having events or you're worried about the risk of having events because they're poor substrate. That's the time to check the HSCRP. The Lodoco trial, has anyone used colchicine? Secondary prevention? Okay. So the Lodoco trial was patients with chronic coronary disease, so stable patient population randomized to colchicine 0.5 versus placebo. And you saw here 31% reduction in cardiovascular death, MI, stroke, or revasc. But on the other hand, you saw a slightly higher risk of non-cardiovascular death. So starting somebody on an anti-inflammatory is a big deal, right? Because you're basically turning off their immune system. So this is not one I use willy-nilly unless there's compelling evidence. Like I said, I've treated all the upstream causes of CRP. They're still having vascular events. The CRP is elevated. That's when I think about using colchicine. And you want to use 0.5, not 0.6. We also saw in the Colcott trial, which was a 30-day post-MI trial, a lower risk in patients who got colchicine versus placebo, a 23% lower risk. But here's what confused everyone. Clear synergy. This was an acute MI trial, and we saw absolutely no difference in the colchicine versus the placebo group, and you saw a higher risk of diarrhea and other adverse events. So this has really got people scratching their heads, is that it's not just about turning off inflammation, it's about turning it off at the right time. So post-MI, when you've just had your MI, you need that inflammation to actually heal your MI and to recover from it. Remote from your event, you can turn off the inflammation. And so it's raised some interesting questions about how we think about our secondary prevention drugs and timing them at the right time. You don't just use things willy-nilly. If you are going to use colchicine, use it not in a recent MI patient, like at least 30 days out, or chronic stable CAD patient. Use only 0.5, don't use the 0.6. Because the therapeutic window is really narrow. And if their GFR drops, you can get yourself in trouble. You certainly can't use it for GFR less than 30, but I would say even if it goes below 60, stop it. You don't want to be messing around with colchicine when the GFR, the renal function, is impaired. You don't want to use it with any other medications that can interfere with it. You want to be careful in the elderly. And again, because there's so much concern about hepatic and renal function, I myself has only written colchicine a handful of times. The last thing I'll leave you with about colchicine is that the duration of therapy. It's not a forever drug. At least we don't think so. You know, in the trial, they started it for 1 to 2 years. Do we need to put somebody on colchicine for the rest of their life just because their CRP came out elevated a couple of times? Probably not, but we don't know the answer to this yet. So really think about inflammation as the final common pathway of all the other bad things that are going on with the patient, the obesity, the triglycerides, the diabetes, the kidney disease, what have you, and then think about colchicine. And then finally, the last thing I'll talk about is the icosapentaethyl pathway, which I'm not using as much anymore. Because if I have a diabetic with elevated triglycerides who's had an event, well, guess what I'm reaching for? GLP or SGLT, right? So I'm going upstream and treating the diabetes, which usually ends up fixing the triglycerides. But I will say, to answer your question, that it has a complementary role. It actually changes the plaque differently than a GLP does. So even though the Reducer trial was done in an era when we weren't using GLPs, so we didn't really know that we could go upstream and treat with GLPs, we see now that there are different downstream effects of these two drugs. So GLPs change plaque in a different way. IPE actually does reduce total plaque volume, reduces the vulnerable plaque, reduces non-calcified plaque, and the necrotic core, and changes fibrous cap thickness. They're also doing some proteomic studies looking at GLPs and IPE together, and what they found is that it changes a lot of the pro-inflammatory markers in your gut as well when you use those two medications together. So I would say if you have somebody on a GLP who still persistently has elevated triglycerides, then you need to think about using icosapentaethyl for secondary prevention. So what a world we live in, right? Think about all the risk-reducing medicines that have exploded on the scene of preventive cardiology just in the last few years. And I didn't even talk about non-steroidal MRAs. I didn't even talk about some of the other medications that are coming. But there's just a lot out there. So when you're thinking about secondary prevention in your patients, remember, you want to take a step back just from the LDL and really try to find those target signs, better risk stratify them, use the CKM staging, and then figure out which pathways you want to target and how. So the obesity metabolic syndrome pathway, the inflammation pathway, the icosapentaethyl pathway, and then of course the lipoproteinase pathway. So thank you so much for your attention. With that, I'll just open it up to questions and comments and reactions.
Payal, thank you. Just knowing that we're 15 minutes over time and probably going to road into the next session, we're going to ask folks to come up to you perhaps instead. You'll be popular after this. So we'll conclude this session. I want to thank our speakers, audience for participation and questions as well, and our panelists.